My name's Jane G. I'm a faculty member in the School of Medicine and also one of the organizers of the HERE Symposium. It's my pleasure to introduce the moderator for this next plenary presentation session. Dr. Alejandra Rincon, the Assistant Vice Chancellor for Diversity and Outreach, will be our moderator. Dr. Rincon.
Good morning, everyone. Oh, we could do a lot better than that. Good morning, everyone. Yeah, that's much better. We have coffee there if you need to perk up a little. All right, good morning. We're happy to see all of you here, and it's my pleasure to introduce our next set of speakers. I'm going to call you up to the podium and ask you to please join me up here. First, Sepide Bon Iva. Second, Joseph Ibu Nike Okoyai. Third, Jessica Fields. Last but not least, Jarmin Ye. Please join us here. Thank you. Thank you. I'm missing one speaker. Oh, here they are. Okay. So, Sepide, you will go first, and your presentation is loaded. And there's a speaker.
Good morning, everyone. I'm so excited and honored to be here today at HERE Symposium in person. I really enjoyed the first plenary session and also poster presentation. It was great. My study is about disparities in dental care utilization among intimate partner violence survivors, which is a TikTok qualitative analysis. So first, I wanted to apologize for the content of the presentation that may, cause discomfort and distress. So, but it's a difficult topic to talk about, but it's really important. Domestic violence, as you know, is one of the serious, silent public health issues. It affects physical, mental, oral health of survivors. And 1 in 3 women and 1 in 4 men experience domestic violence in their lifetime. 20 people per minute per day experience domestic violence in the United States. Only 34% of people who are injured by domestic violence, they get access to care. 20,000 calls placed every day about domestic violence. There is an increase of 500% of violence and suicide because of gun being present at home. And 94% of those who are affected by murder-suicide situation are women. And primary age group of those who are experiencing domestic violence are 18 to 40 years old, which when I was walking through poster session and viewed different posters, this is a group that really experienced different and difficult situations like cannabis use or violence or different health situation. 65% of head and orofacial injuries are related to domestic violence, and this include head trauma, face bruises, lip laceration, nose fracture, tooth fracture, jaw dislocation, tooth loss, and tooth avulsion. So tooth avulsions means that the severity of the blow or trauma is in a way that the whole tooth comes out of bone. So that's really severe. Survivors experience various challenges in getting care, including dental care and access to different resources or different type of support after they experience domestic violence. So this raised two questions for me to study. What information is in social media as one of the resources one of the platforms that survivors or different group of people refer to get information, and what challenges domestic violence survivors experience to get dental care. So the study aimed to analyze TikTok videos on domestic violence and or facial injuries and survivors, challenges to access to dental care. I'm not a TikTok user. This is kind of like Gen Z type of platform, but I had to create an account in TikTok to analyze the videos. And as I mentioned, 18 to 24 years old are those group of people that unfortunately experience different difficulties, different situations like violence. And as you can see, 29% of 18 to 24 years old and 16% of 25 to 34 years old, they are TikTok users. TikTok, as you know, it's a video sharing app available since 2018. 2 billion people downloaded in the world, and over 130 million people downloaded TikTok in the United States. And currently, based on data in 2022, there are 1,000 million users. The study time frame was from September 1st to October 15, 2022. Initially, I used different search terms to extract videos that are related to domestic violence and orofacial injuries and dental care challenges. But at the end, I come up with just two sets, domestic violence dentistry and domestic violence tooth fracture, that helped me to extract 50 top videos from each to analyze. And the qualitative analysis of videos included using global quality scale, which I'm going to explain in a minute, video sources, survivors' gender, or facial injuries type that mentioned or presented in TikTok, and dental care barriers and challenges, dental care received and available resources. And the main themes of the content of the videos also was extracted. Inclusion criteria were those videos that obviously had sound and in English, were posted by adults for adults, were posted by domestic violence survivors or their families or healthcare providers, social workers, or any organization that are working on this subject and supporting domestic violence survivors. Exclusion criteria were advertisement videos, animations, and duplicated videos. The global quality scale that I used for this analysis is a scale that is used for assessing reliability and quality of website or videos, and in the literature, it has been used for TikTok videos as well. It has 5 scores, one being poor quality, poor flow of the site or video, lack of information and not useful for patients, and 5 being excellent quality and excellent flow and very useful for patients. The results. The results of this study showed that 93% of videos were posted by layperson. Only 4% of videos were posted by dentists, healthcare professional, or different organizations, which is sad. And 3% by news agencies or TV news. 48% of videos posted by layperson was to raise awareness about sign and symptoms, domestic violence hand sign, phone conversation with 911 if perpetrator is present, resources, hotlines, and so on. 98% of videos were posted by women who were victims or survivors of domestic violence. Physical injuries that presented in TikTok videos included bruises, cheek fracture, hearing loss, tooth injuries including fractures, avulsion, cracked tooth, tooth loss, jaw fracture, and dislocated jaw. Dental care was one of the challenging situation for domestic violence survivors, and they included fear of calling or visiting a dentist, prolonged or delayed treatments, and financial hardship to get dental care. And those survivors that were able to get dental care, they had received different treatments based on the severity of the situation, so including tooth color restoration, crown bridge, implant, oral surgery, or tooth extraction. The main themes that were extracted from the content of the videos were explaining about dental treatment costs, seeking financial resources or donations through social media, TikTok, for dental care, losing confidence because of appearance, and experiencing post-traumatic stress disorder. And some less frequent themes were deaths resulted by domestic violence family members that reported, and abuser being a woman, victim blaming, and neighbor who helped the situation. Mean global quality score for orofacial injuries that presented in TikTok and domestic violence situation that presented in TikTok was 4.5 out of 5, but it doesn't mean that the information about dental care that was challenging was enough. In conclusion, there is a lack of valid and reliable dental care information in TikTok, and obviously, disparities and inequities exist. There are not that many information about dental care, access to dental care, resources available for survivors, and financial hardship that they experience, and how they can deal with the situation if they have orofacial injuries. Some suggestions that we can make is that I think it's really hard to go through using social media, because we are not used to that much. So we have to use social media platform and leverage social media to reach to larger audience. I just wanted to show you this hand sign that if you see in your patient showing, so palm towards you, thumb will be inside your hand, and then tie your thumb. So this shows that the person is in danger for domestic violence. Thank you so much.
Nice to see you again.
All right. Good morning, everyone. All right, and I apologize if my afro covered the slides for a lot of you, but we'll move right along. So, yes. Hello, my name is Joseph Ibonike Okoye, and I'll be presenting, Because the Darkness of My Skin, I Know It Can Go Down Quick, a qualitative examination of the impact of police violence on the mental and physical health of Black and Latino men who have sex with men in California and New York. Great, so briefly I would like to take a moment to acknowledge our team who made this all possible, and a special thank you to Dr. Orlando Harris, who unfortunately is not in attendance today, but offered his platform for me to present here today. All right, so interactions between police and people of color in the United States often result in various forms of violence. Police violence disproportionately impacts Black and Latino men, and Black and Latino men who have sex with men are at increased risk of violent encounters with police resulting from their intersecting identities. So the goal of this study was to explore the impact of police violence on the mental and physical health of Black and Latino men who have sex with men in California and New York. So we conducted qualitative interviews across California and New York from March 2022 to January 2023 of this year. We proposed the following research questions to gain better insight into Black and Latino men who have sex with men's perception around police violence and the recent racial justice protests during 2020. We interviewed 41 participants, 20 in California, 21 in New York, and our sample consisted of 44 individuals. We employed a qualitative, interpretive phenomenological research design and utilized thematic analyses to identify themes. And through this research design, we identified 4 themes, as you can see here. And the first theme that emerged was maintaining safety through awareness. So participants maintain their safety through awareness of the harm or violence, that can be directed towards them as a result of their race, gender identity, and sexual orientation. As a coping or harm reduction strategy, maintaining safety also included avoiding large crowds or venues that were perceived as vulnerable to bias-motivated attacks. Participants also expressed their fear and anxiety of being in large crowds or frequenting public queer spaces. One participant recognizes the targeted violence against queer people and people of color, inducing feelings of fear, as these are his identities and communities that are being targeted, as you can see in this quote here. Limiting the need to go out into public or not physically participating in the racial justice protests during the pandemic were risk reduction strategies. Many participants considered actions to secure their safety from the police. For example, one participant evaluates their chances of running into conflict when describing their neighborhood in Harlem, which emphasized when given the chance, he would stay inside to prevent any possible situation with the police to protect his peace of mind. Great. The second theme that emerged was the direct and indirect involvement in the racial justice movement. The racial justice movement during the pandemic was seen as an opportunity for participants to become involved in their community. However, participation in the racial justice movement was mixed, with some having either direct or indirect involvement. Many participants shared their concerns of exposure to COVID-19 during the racial justice protest. For example, one participant states that they were not comfortable attending, knowing of others who did attend and tested positive for COVID-19. While fear of exposure presented as a major reason for participants not directly participating in the racial justice protest, participants also shared their feelings of exhaustion and defeat on the topic of ongoing police brutality against Black people. This experience is true both for those who indirectly as well as those directly who participated in the racial justice protests. One participant explains their experience when reflecting on the highly publicized deaths of Breonna Taylor and George Floyd, mentioning just the simple fact that we were feeling tired, as in like, I'm tired of doing this. I'm tired of having to hear about more violence, and this is, at the time, I don't know, the 15th, 16th killing, something like that, and I'm tired of waking up and there's another Black person dead because of the police or somebody acting like they're the police. Tired of having to go to these rallies and stand up for human rights. So that was definitely the biggest negative aspect for me. It is like, emotionally, it's like, yes, I want to be there and support and stand in solidarity, but at the same time, I'm really I'm really tired and emotionally and mentally, just like tired of having to do this. And when is this going to end, you know? Okay, great. A significant portion of participants who did directly participate in the racial justice protests expressed that the experience to be cathartic as they stood up against racial injustice in community. A participant states, here it is. A participant states, getting to see the Black community come together in solidarity for change, being a part of something that I have never been a part of, standing up for our rights and for justice, I would say was, positively speaking, something that affected me. The third theme to emerge was the impact of violence on mental health, structural violence through the use of police violence, and the resulting racial justice protests impacted the mental health of participants, while some participants participated in the racial justice protests as a coping mechanism and engaged in other forms of self-care practices. although others express lack of social support or not being able to express their feelings or engage in self-care. For example, one participant describes their experience around the racial justice protests during the COVID-19 pandemic. It was like if you had a wound, you cut yourself or something, and someone pours vinegar or salt in your wound. That's how it felt. It just felt like I was just completely raw, and everything that was seemingly happening simultaneously was triggering all the experiences of discrimination that I've encountered in my entire life, that I experienced alone. Participants also revealed police violence impacted their ability to express their feelings, engage in society, and also with themselves. One participant describes this experience to be the desire of divorcing himself from the world, highlighting patterns of disassociation among participants. The fourth theme that emerged was the intersectional experience of structural and LGBTQ-related violence. Intersectional experiences of structural and LGBTQ-related violence emerged as compounded factors impacting the lives of participants. This includes the experience of structural violence from the hands of police, LGBTQ-related violence that participants faced as a result of their gender identity and sexual orientation, and the social support structures that created to cope with these intersecting forms of violence. One participant states his understanding of his intersectional identities and the risk it perpetuates to police violence based on the numerous cases of others who look and identify similar to him. One participant also shared their susceptibility to other forms of violence due to their queer identities. One participant recalls his experience of being physically assaulted due to his effeminate nature. Through the multiple forms of risk to violence due to their intersecting identities, participants reveal the need to put up a mask or false selves for their survival and protection from these various forms of violence. One participant highlights their experience of developing these masks and its resulting detrimental impact on the ability to process traumas they faced in their life. Great. So our findings suggest that police violence negatively impacts the mental and physical health of Black and Latino men who have sex with men, and further erodes trust between law enforcement and communities of color. Quantitative assessments of these issues are needed to scale these compounding intersections of police violence, the racial justice movement, and LGBTQIA+ related violence on sexual and gender minorities. Healthcare and mental health providers must employ culturally tailored mental health support strategies that directly speak to the needs of these communities. And lastly, public health and policing reforms are urgently needed to address the impact of these experiences on the lives of Black and Latino men who have sex with men. And lastly, I would like to thank each and every study interview participant as their time, insight, and expertise make this and preceding work possible. And I would also like to thank the funders of this study. And thank you all for your time.
All right. I'm Jessica Fields, a third-year student in the UC Berkeley UCSF Joint Medical Program, and today I'll be talking about our study looking at factors associated with acute healthcare use in a representative sample of adults experiencing homelessness in California. Over 170,000 people experience homelessness nightly in California, about 2/3 of whom are unsheltered. We know that poor health increases risk for homelessness and that homelessness is detrimental to health. Due to a high prevalence of comorbidities and poor access to longitudinal health care, people experiencing homelessness are at high risk of emergency department use and hospitalization. However, what we know about healthcare use and access among people experiencing homelessness is outdated. The only large representative study is now nearly 30 years old. Since then, the homeless population has aged, we've seen a large increase in unsheltered homelessness, and 40 states have expanded Medicaid. More recent studies are small and single site, or only include people who are already accessing services, whether shelters, meal programs, or healthcare. So they're not representative of adults experiencing homelessness and are not generalizable. In our study, our objective is to describe the prevalence of and factors associated with emergency department use and hospitalization in a representative sample of adults experiencing homelessness in California. We used the Gelberg-Anderson behavioral model for vulnerable populations to guide our study design. According to the model, healthcare utilization is a function of individuals' predisposition to use health services, called predisposing factors, factors that enable or impede such use, called enabling factors, and factors that determine people's need for healthcare, called need factors. These predisposing, enabling, and need factors together predict health behaviors, which include health services use. Within predisposing factors, we included various demographic characteristics, as well as additional contextual factors related to individuals' histories of incarceration, homelessness, and perceived discrimination. Within enabling factors, we included having insurance as a personal resource, as well as a zip code level of urbanity as a measure of community resources. Within need factors, we included information about participants' physical health, perceived general health, experiences of physical or sexual violence, substance use, and mental health. And our dependent variables were any prior 6-month use of the ED or hospitalization for a physical health need. We used data from the UCSF Benioff Homelessness and Housing Initiative's California statewide study of people experiencing homelessness, which involved a large cross-sectional survey with multi-stage sampling, including venue-based sampling and supplemented with respondent-driven sampling. Field teams administered questionnaires in person in multiple languages from October 2021 through November 2022. For our statistical analysis, we applied survey weights to generate representative statewide estimates. We constructed multivariable modified Poisson regression models sequentially in alignment with the Gelberg-Anderson model and report prevalence ratios. So essentially, for each domain of the Gelberg-Anderson model, we adjusted for the prior, more upstream domains. So for demographics, we report unadjusted prevalence ratios. For contextual predisposing factors, we adjust for demographics. For enabling factors, we adjust for all the predisposing factors. And for need factors, we adjust for predisposing and enabling factors. Our study sample of 3,200 individuals had a median age of 47, was 2/3 cis men, about a quarter identified as Black, a quarter as Latinx, a quarter as white, and a quarter as multiracial or another race. About 3/4 of the sample were unsheltered, and nearly half reported fair or poor general health. Overall, we found that in the prior 6 months, 39% of adults experiencing homelessness in California visited the emergency department, and 22% were hospitalized. In multivariable models, we found that cis women had 1.3 times the prevalence of ED use relative to cis men, and that Spanish speakers had 0.58 times the prevalence of ED use relative to English speakers. Of enabling factors, we found that having health insurance was associated with 1.46 times the prevalence of ED use relative to not having health insurance. And in terms of need factors, mental illness symptoms, including depression, anxiety, and hallucinations, were associated with higher prevalence of ED use. In multivariable models examining factors associated with hospitalization, we found that participants' racial identities, specifically Black and multiracial identities, which we use as proxies for exposure to structural racism, were associated with increased prevalence of hospitalization. Of enabling factors, having insurance was associated with nearly double the prevalence of hospitalization. And of need factors, impairments in activities of daily living, self-reported fair or poor health, having experienced physical or sexual violence during the current episode of homelessness, and experiencing hallucinations were each associated with increased prevalence of hospitalization. So to put this in context, we can compare our findings to acute care use in the low-income housed population and to the large prior study of people experiencing homelessness from the mid-1990s. So we found that 6-month acute care use among adults experiencing homelessness was about double the past year use among the housed low-income population of California. Further, we found that the 6-month ED use rate was higher and hospitalization was similar to past 1-year use reported among adults experiencing homelessness in the national study from the mid-1990s. These high acute care use rates point to the need for coordination between the acute healthcare system and the homelessness response system. That need factors were associated with higher acute care use points to the high level of health need among adults experiencing homelessness. Further, that the association between mental health problems with both ED use and hospitalization points to the need for mental health interventions and support in this population. Our findings also show that while insurance is insufficient to avoid acute care use in this population, it may facilitate access to needed care, though this relationship is likely bidirectional, with people also being enrolled in insurance upon presenting to acute care settings. With an aging homeless population, we also expect acute care use to continue to rise in this population. And overall, the high acute care use rates that we found confer urgency for healthcare providers and systems to advocate for structural changes that can reduce and prevent homelessness. Limitations of our study include that it was cross-sectional and we cannot assess causality. In addition, we don't have information on the reason for healthcare use. Strengths include that we used rigorous representative sampling and weighting. And in terms of policy implications of this work, our findings support the importance of CalAIM, which enables Medi-Cal reimbursement of housing supports for patients. Our findings also highlight the importance of programs and policies to address gender and racial inequities arising from structural oppression and to fund language interpretation services, violence prevention, and mental health care for people experiencing homelessness. Lastly, this work reinforces that reducing homelessness by prioritizing deeply affordable and permanent supportive housing may reduce acute care use in this population. And I'd like to end by acknowledging my incredible co-author team pictured up here, my mentors, and the funders of this work. Thank you so much.
Thank you and good morning. My name is Jarman Ye. I'm an associate professor at the Institute for Health and Aging. Today I'm going to tell you about a project that seeks to train a workforce to provide in-home care to older adults living with Alzheimer's disease and related dementias. Home care workers help people living with Alzheimer's disease and related dementias to age in place. However, more are needed as the U.S. population grows older and the prevalence of ADRD increases. ADRD, like so many other diseases, disproportionately impact people from Black, Indigenous, and people of color communities for a variety of reasons associated with upstream inequities in the social determinants of health. Consequently, we see disparities in outcomes in these historically marginalized populations. For instance, this slide shows the prevalence of Alzheimer's disease in California stratified by race ethnicity categories. By 2040, the number of Californians living with Alzheimer's disease who identify as Latinx or multiracial will triple. and for those who identify as Black African American, Native American, or Asian American Pacific Islander, the prevalence will double. As dementia progresses and cognition declines, many people living with AD-RD will require increasing levels of assistance, which may necessitate assistance from paid home care workers. Nationally, the home care workforce constitutes 58% of the total direct care workforce, which is the fastest growing occupation in the United States. The competence of home care workers to serve people living with AD-RD and address adverse social determinants of health is critically important for integrating home and community-based care and into long-term care systems. Systemic drivers, however, perpetuate inequities for the home care workforce and people living with AD-RD alike. The unequal allocation of home care labor by gender, race, and class plays a critical role in the reproduction of social stratification. Many come from historically marginalized backgrounds. About 1/3 are immigrants. The majority are people of color. Women receive public assistance, have their highest educational level at high school, and live in low-income neighborhoods. Despite the vital work that they provide, home care workers continue to be underpaid, underrecognized, and undervalued. As the need for more home care workers grows, so do the expectations for their roles as they provide increasingly higher levels of care to clients with complex conditions such as AD-RD, while receiving very little formal training to do so. Therefore, the IHSS plus AD-RD training project seeks to implement and evaluate the impact of a 10-week instructor-led, competency-based online AD-RD curriculum with IHSS caregivers and their consumers who are older adults living with cognitive impairment. This project is funded by the California Department of Public Health. UCSF has a partnership with the Center for Caregiver Advancement, a nonprofit founded by SEIU Local 2015 Long-Term Care Workers, and Alameda Alliance for Health, a Medi-Cal managed care plan. This intervention is a training program provided to 600 IHSS caregivers in Alameda County and 120 in LA County. The classes are offered in English, Spanish, Cantonese, and Mandarin languages. I'm going to focus on Alameda County for today's talk. Our broader theory of change is that training caregivers will increase their dementia knowledge and self-efficacy to care for consumers living with AD-RD, thereby decreasing their consumers' utilization of costly health system resources such as emergency room visits and hospitalizations. We used a quasi-experimental longitudinal design looking at pre, post, and 3-month follow-up surveys to assess caregiver outcomes and administrative records pulled 1 year before and after training to compare healthcare utilization patterns of their consumers. Caregivers were recruited through a union contact list via phone, text message, internet, and social media outreach. For the remainder of this talk, I'm going to focus on our preliminary findings to date, which includes outcomes for caregivers in the first 4 of 5 cohorts. As you can see from this flowchart, a total of 483 caregivers completed the training, 206 were included in our analytic sample, and of those, 124 were in the English classes, indicated in red, 28 were in the Spanish classes, indicated in blue, and 54 were in the Cantonese classes, indicated in purple. Overall, caregivers in all 3 classes were similar. The mean age was between 49 to 53. Over 80% were women. Caregivers in the English classes had slightly higher education than those in the Spanish and the Cantonese classes. Most caregivers were a daughter or a son to the consumer, did not live with their consumer, have been caring for the consumer for 1 to 5 years, and worked between 10 to 40 hours a week. Over 80% of the caregivers were satisfied with their job. We used the DCAT-2, a validated self-assessment, to evaluate changes in dementia knowledge before, after, and 3 months following the training. This measure includes 21 statements that respondents read and answer yes, no, or don't know. In this figure, we see the mean scores on the DCAT-2 significantly increased between pre-training and post-training, and between pre-training and 3-month follow-up for caregivers in the English, Spanish, and Cantonese classes. This pattern is trending in the desired direction of change and may even suggest retention of knowledge at 3-month follow-up. We use the Fortinsky Self-Efficacy Scale to assess confidence caring for a person with dementia. This instrument includes 10 statements that respondents read and respond using a 1 to 10-point rating scale. The statements are clustered into 2 domains. The figure on the left shows the symptom management domain, and the figure on the right shows the community support service use domain. In both figures, we see the mean score significantly increase between pre-training and post-training, and between pre- and 3-month follow-up for all classes, which is the desired direction of change. We do see some variation in mean scores between the classes, which merits further exploration. We also asked caregivers if they knew about health system resources offered by Alameda Alliance, including urgent care, member services, the nurse advice line, and behavioral health services. Again, we see the same patterns of knowledge gained between pre- and post-training, as well as between pre- and 3-month follow-up for all 3 classes. At post-training, the majority of IHS's caregivers agreed the training was beneficial. They learned new caregiving skills, communication with their consumer improved, the instructor made them feel comfortable, and the instructor effectively answered their questions. The majority were satisfied with the training overall. We looked at administrative records pulled 1 year before and after the training to compare healthcare utilization patterns of the IHS's consumers. Due to this lag time, we currently only have data for consumers of caregivers trained in the 1st and 2nd cohorts. We found that consumers had a mean age of 73. Most consumers were women, and Hispanic, Latinx, Asian American, or African American. When IHS's caregivers were recruited to this study, they were asked to provide their own assessment of their consumers' cognitive status using the Washington University Dementia Screening Test called the 88. It's a validated screening measure that differentiates between signs of normal cognition and mild dementia. Therefore, a dementia or Alzheimer's diagnosis for the consumer was not a necessary inclusion criterion for caregivers to participate in this project. However, we did look at diagnoses in the data that we received. In the top table, we found 19% of consumers had a dementia diagnosis before their caregiver took the training, indicated in the green, compared to 24% after the training, indicated in blue. Likewise, in the bottom table, we found 9% of consumers had an Alzheimer's diagnosis before their caregiver took the training, compared to 15% after. We're unable to draw conclusions about the interpretation of these data. However, they could suggest that there is low detection of dementia and Alzheimer's among primary care providers, and that training caregivers could improve their ability to encourage a dementia screening when they go to the doctor with their consumer. This figure shows the aggregate healthcare utilization patterns for admissions to skilled nursing facilities, hospitalizations, ER visits, telehealth, and office visits 1 year before and after the consumer's caregiver took the training. While we hypothesized a decrease in ER visits and hospitalizations, we don't see those trends here. However, these data fall squarely during the onset of the COVID-19 pandemic and shelter in place, so we're unable to fully understand how the pandemic impacted these utilization patterns at this time. We do hypothesize that an increase in telehealth and office visits may suggest improved primary care prevention, so these trends could be ideal. So we're only at the beginning phases of our data analysis, but we have more plans for subsequent analyses to further understand the outcomes on caregivers and consumers. And I will just wrap up really quickly because I think that I am at the end of my time. That the take-home message is that home care workers are frontline workers and often first responders. Our results reveal promising signs that caregivers do value training. Training a workforce to provide in-home care to people living with AD-RD is an upstream intervention that aligns with broader efforts to create age-friendly and dementia-friendly communities, and downstream people living with AD-RD and their caregivers may be better able to age in place, which could help health systems save money. So the implications here are to expand workforce training, including which would fulfill the governor's goal to create 1 million high-quality caregiving jobs in 2030 as part of the California Master Plan for Aging. And gratitude to our partners, the research team, and references and contact information.
Thank you. That was wonderful. Let's give them another round of applause. That's fantastic. All right, I want to open it up for questions from the audience. Do I have any questions to kick us off? Yes.
Hi, thank you. Really wonderful presentations again. The question about the unhoused, in terms of the utilization, did you distinguish whether it was voluntary or involuntary?
Great. Oh, is this on?
Yes.
Yeah, okay, great. Great question. Thank you so much for that. We did not distinguish. As I mentioned, we don't have information on the reason for health service use. What I will say is that the hospitalization outcome that we were looking at was physical health hospitalization only, which was distinguished from a mental health related hospitalization. So we were not looking at like 5150s, for example.
Thank you. Other questions?
Okay, great. Yeah, thanks. I again, loved the presentations. I'm Hal Collard again. I had a question. Is that right? So you had a bullet at the end about next steps and qualitative interviews. I want to put a plug in for qualitative methodology as an important, important aspect of this type of research. And I'm just interested in, you could use that both to kind of understand the impact that maybe you're not seeing in your, let's say, your other, more quantitative metrics, but also perhaps understand why you're not seeing quantitative, like maybe there isn't an impact. So I'm just wondering how you're planning to approach your qualitative strategy and how you see that leading to kind of more hypotheses.
Yeah, I am a big fan of qualitative research, and we're just starting to conduct. Yes. I'm a big fan of qualitative research, and we're just starting to conduct. This one's not working. Thank you. I'm a big fan of qualitative research, and we're just starting to conduct those now with the caregivers that completed the training to better understand their experiences. And so we've been following up with those that are interested to speak with us, to tell us a little bit more about their experiences, their entree into the field, some of the things that they find themselves doing that they haven't been trained to do, and also their career aspirations beyond caregiving. We are finding that many of them, especially in the IHSS population, which is a really sort of unique population because many are family members that started doing this because they were already caring for a family member. And the IHSS program is a way to get a bit of compensation for work that they're already doing. Some come into it as a career pathway. So that's been a really interesting thing that we've been exploring and asking about, and what aspirations people have for after this program, for themselves as well. So those are some of the things that we've been looking at. In terms of how COVID has impacted this, we do have some questions there. And it's been interesting because I think when shelter in place happened, the primary concern was having protective equipment. And now that things are opening up, the caregivers actually sound like they're spread thinner because they're running around a bit more than they were before. And even taking and completing the training classes have been more difficult for them than it was during the pandemic. And when we talk with Alameda Alliance, they certainly said, we shut everything down, everything sort of switched to telehealth, telemedicine, so they weren't seeing people in person in the same way as they were before. So.
Hi, thank you all for your presentations. This question is also for Jarman. I'm curious if the caregivers were compensated for completing the training and if the training addressed caregiver burnout, because I know that's a huge problem with home care.
Yeah, that's a great question. The caregivers were compensated $300 for participating, and the training curriculum does address burden and stress, and we actually have a few outcome measures looking at that as well, which are difficult for us to interpret also with COVID, the COVID pandemic layering on top of everything, so we have to do a little bit more digging to better understand that. But it does certainly come up, especially working with people with cognitive impairment and the stressors that they face, with psychosocial behaviors and wandering and other aspects of their care work. Yeah, great question.
Thank you. You had a question here?
Hi, my name is Carrington Osborne, and this is a question for Joseph. And one of the things that struck me in your presentation is when you talked about police violence, one of the things that came to mind for me is often when gay and lesbian, bisexual, and transgender people of color report violence to the police, how they're treated, to me it seems like that in and of itself is a mental type of violence. And my question is two parts. One, would you agree with that? And then secondly, it sounded like Black Lives Matter protests had a positive impact on people. So would you also advocate for community involvement, political activism around helping to improve the mental health of Black and Latino men who have sex with men?
Great. Great question. Twofold question. So for your first part of the question, I believe it was, I'm blanking, but it was, can you repeat the first part?
Mental health violence in terms of
Yes.
lack of response from the police.
Yes. So yes, I definitely agree. And if you actually search up the definition of police violence, there is no academic definition of police violence. So how we've been classifying police violence is any form of violence, physical or psychological, perpetuated by police. And this includes provoking or degrading language, racial profiling, and physical assault, and the various, not limited to those. So yes, I definitely agree with that. And to your second question, I extremely advocate for that in terms of community building. Both, I think when we think about research and the trajectory of a lot of research, at least community-based participatory research, including the community in the research, right? And I think there's a lot to build there and a lot of work Dr. Harris is actually moving towards, and I think there's a lot of value in that, in building the community in the work, right? So yeah, I guess I'll answer it there. Thank you.
Thank you. We have time for maybe one more question. Yes?
First of all, thank you very much for very interesting presentations. My question is to Jessica, to get your take on the new California care courts, specifically how that's going to impact the BIPOC population.
Sorry, could you just repeat the second half one more time?
Your take on the California so-called care court practice, and specifically how that is going to impact the BIPOC population.
That's an excellent question, and it's interesting, sort of separate from this work, I've been talking with a friend of mine who's a social worker about that. I will say that unfortunately, I think I'm not prepared to give as good of an answer to your question as I would like to, and would have to do some more reading. But I will say that I think in general, one thing I want to bring up is that while mental health problems were associated with higher acute care use, and what we found, substance use actually wasn't, and which is bringing up for me that like the experience of homelessness was really the destabilizing thing here. Though again, I really appreciate your question, and unfortunately, I don't feel prepared to answer it. Thank you, though.
I have 2 more minutes. Okay, I give an extra time. Yes, we have a question here. I do.
Thank you. Hi, my name is Diana. I was part of the posters from the morning. I had a question for Jarman. So I'm actually a caregiver as well for my grandma for IHSS, but I was wondering, this might be out of scope, but how do you see your research impacting overall research for dementia and Alzheimer's, and how does that turn back into supporting the IHSS community?
That's a great question. We certainly hope that this work demonstrates both positive changes in caregiver outcomes and consumer outcomes. Our project partners, the California Center for Caregiver Advancement, has received a grant to also roll this out in San Bernardino County. And so more and more counties seem to be taking it up. And so as we gather more evidence to support this work. That's really encouraging. I think the other piece of it too is having some data and evidence to advocate for higher wages and better working conditions for IHSS caregivers. Again, it's an interesting population because it sort of straddles the boundary between formal and informal caregiving. And so, one example is the state has started something called IHSS Pathways Program, which are training programs for IHSS caregivers. And those are, caregivers get compensated for that training. And so the work that we're subsequently doing now, to your earlier question, pays the caregivers much more to participate in the trainings and also to complete our evaluations so we can better understand the impact of what these trainings are doing. And so this is all part of building, I think, the evidence base for pushing policy for both the IHSS caregivers and their working conditions, and then care for consumers at home so that they can stay out of nursing homes and institutions. Thank you.
Okay, do I have time for one more question, or? Okay, I actually have a question for you, Sepide. What were the years of your study? I'm not sure that I heard that, and was there any intersection with like big political movements like the Me Too movement and the uploading of the videos during any of those times?
It was about 2022, so it was after that time, but actually it was during COVID-19, which in the beginning we kind of expected that it's the number of violence increased because of everyone staying at home. So I was really interested to know what's going on in people's lives and through social media. Yeah, that was in the middle of COVID-19.
Excellent. Well, thank you. Let's just give them another round of applause, please. Thank you. Okay, just help me welcome Dr. Renee Navarro, Vice Chancellor for the Office of Diversity and Outreach. Thank you.
Wow, what a morning so far. I tell you, I just want to take a minute to first thank the moderators for this morning's panels, Dr. Jomans, Dr. Alejandro Rincon, for all of the presenters, for the posters. They were outstanding, for all of the folks who presented. Let's give them all another big round of applause. Just fantastic. So now I have the privilege to introduce our next speaker, and it's someone that I'm proud to call a colleague and a friend and a longtime collaborator on the ongoing efforts to achieve health equity here at UCSF and throughout. That's Dr. Tung Nguyen. Dr. Nguyen graciously stepped in offering to present today when we had a last-minute, unexpected, and unavoidable change in our agenda. We thank him for his generosity, and I'm very happy to have him be a part of the HERE Symposium leadership. Dr. Nguyen is a professor of medicine at UCSF and serves as the inaugural Associate Vice Chancellor of Research, Inclusion, Diversity, Equity, and Anti-Racism, IDEA. His research focuses on achieving health equity using community-based participatory research, patient-centered outcomes research, and other stakeholder-engaged methods. Dr. Nguyen has conducted intervention research using social networks, traditional media, mobile applications with culturally and linguistically diverse populations on breast, cervical, and colorectal cancer screenings, patient navigation, tobacco control, hepatitis B and C screening, nutrition and physical activity, as well as end-of-life care. He is nationally recognized for his work in community-based participatory research and is the first author of a chapter, Science of Health Disparities Research textbook, which was published by the National Institute on Minority Health and Health Disparities. Dr. Nguyen is a principal investigator of our UCSF Clinical and Translational Science Institute. He's the director of the Research Action Group for Equity, RAGE program, which aims to increase diversity among research participants. And he serves as a leader on the National CTSI DEIA Enterprise Committee. At the UCSF Helen Diller Family Comprehensive Cancer Center, Dr. Wen is Associate Director of Diversity, Equity, Inclusion, and Accessibility and co-leader of the Cancer Control Research Program. He's also the principal investigator of the San Francisco Build, an NIH-funded partnership between UCSF and San Francisco State University to promote health research workforce diversity. He's a bilingual, first-generation Vietnamese American. Dr. Wen founded the Asian American Research Center on Health, ARC, and served as chair of President Obama's Advisory Commission on Asian Americans and Pacific Islanders. He has founded 2 nonprofit advocacy organizations, AAPI Victory Alliance and the Progressive Vietnamese American Organization, PIVOT, and he has the best acronyms ever. What an outstanding leader. I have to say that you really reflect and represent the very best of UCSF. Dr. Wen, thank you for being here, and we look forward to your talk. Please join me in welcoming him.
That's so nice. Thank you so much. Okay, I'm between you and lunch, trying to make it worth your while. And I'll first will say I apologize to all of those who came to see Dean LeVice speak. I am not Dean LeVice. Second, it is typical in anti-racist work to acknowledge one's privilege, and I have to say that to be on the lead selection committee and giving the keynote talk is definitely incredibly privileged, and I appreciate that. Okay, so I'm here to talk about anti-racism in science. I want to learn to look this way and not that way. In science, health, and research. And I have to say I'm a learner in this area, to be honest. And I actually did this talk, or originally did this talk, not this time, but previously, as a way for me to learn. I'm kind of a doer, learner kind of person. If I don't do it, I don't really learn. And so I'm hoping that to share this with you and your feedback on what I'm saying is going to be very important in my own learning process. So to start with, you don't have to answer this out loud. Well, you can if you want. I want you to ask you this question. What do you value more, the questions or the answers? A, the questions. B, the answers. C, both. D, neither. And E, who are you to be asking me questions? Well, who am I then? Let's start with that. And who am I to be giving this talk? And I'll start with my flimsy qualifications. I'm a person of color, a first-generation immigrant whose parents had limited English proficiency, and thus someone who have experienced some racism, but only some. I am a healthcare provider who take care of patients, many of whom have experienced racism. I'm a researcher who has studied health disparities and health equity, but not racism explicitly. I'm a dabbler in advocacy and policy, and I, of course, most recently started to work on changing our institutional infrastructure for diversity, equity, and anti-racism. And what I'm trying to do in this slide is to point out a few important things. That when it comes to racism and anti-racism, I am not an expert. That's a humility for me. I hope that many of you will approach this work with the same humility. And yet, I'm willing to take on this work. And that's not only a responsibility for me, I hope that many of you will see that as part of your responsibility. As a side note on my research career, I trained to be a researcher in medical school. That's a long time ago, it's last century. But I never got my master's degree in health services research, which was the program I was in. Even though I did all the coursework, I just couldn't find a project that I care enough about and a mentor that I wanted to work with. And this was in the days before the field of health disparities research was really born. So I never did my thesis, and I left research for about 10 years. So when I came back to research to do this kind of work that I've been doing, I went back to my program director, and I said, hey, can I get that degree now? And of course, he said, no. Weirdo. So I am indeed a jack of all trades and formally a master of none. And as such, I am free to challenge the master's tools. And finally, it's important to point out that I will be using the Socratic method a little bit today, asking a bunch of questions, We know that Socrates used this as a way to teach, but I'm learning from reading things that he probably also didn't know the answers to the question he was asking either. And it was the process of exchange between him and the quote-unquote learner where the questions were answered. And I think that's really a fundamental part of anti-racist work as well, that no one, as I said, has the privileged position of only asking the questions. Okay. Here's an outline. Here's an outline of what I want to talk about. I'm going to go through racism in science and health, just some samples. Thinking about ethics through an equity lens, an anti-racist lens. Thinking about anti-racism principles and examples, and then we'll have some question and answers where I will be learning from you. So racism in science and biology. So, So in 1700s, Carl Linnaeus, who was a botanist, created basically modern taxonomy, and he described 4 human varieties. And I don't think you need to know Latin to understand what group he's referring to. He created this group out of some stereotypes, and then they went on to sustain and create new stereotypes. In the 1800s, Samuel Morton, who's a physician, used human skull size in the science of the pseudoscience of craniology and phrenology to argue for racial differences and specifically white superiority. In the 1800s, Francis Galton coined the term eugenics to argue for the breeding of selective traits. Eugenics may seem like wacko to us now, but I thought it was interesting that in 1921, the lead story in the journal Science was about the Second International Congress of Eugenics. That's only 100 years ago that when it was considered mainstream science, and also a reminder for those of us who think a lot about journal impact factor, that a science publication is not necessarily an emblematic of excellent science. I think most of, okay, that was an inside joke for those who care about impact factor, and Dr. Seligman clapped, okay. I think most of us of science agree now that race is not biologically determined. Believe it or not, when I was in training 25 years ago, that was not a settled issue. Just in case you're wondering why we say that, studies of human genetic variation, 94% is found within races and 4% between races. So in a way, I have more in common with a black person maybe than another Asian person, just to say. So sometimes the response to racism is that everyone was doing it, so no one knew any better. It's a bit of a circular argument for me because racism defined who everyone is, in my recollection. So here's an example of someone who, even in the 1800s, knew racism couches biology. So this is Dr. James McCune Smith. He was the first African American to receive an MD. He had to go to Scotland to get it because he couldn't get it in this country. So there's the definition of who someone is or who everyone was. He published 2 articles in the London Medical Gazette, apparently the first 2 science publications by an African American, reporting the unethical use of an experimental drug on non-consenting female patients. I contend maybe that he is the world's first anti-racist scientist. What was about 1921, 100 years ago, not being too long ago? In January 2023, that's this century, the American Society of Human Genetics finally issued an apology for the role its leaders played in the eugenics era. 100 years. It took them 100 years. I don't know what it took them 100 years to figure out they were wrong or to admit that they were wrong. And these are people who do research, right? They know that they can't take decades to figure out things. They know they had to do it quickly, and it took them 100 years to figure this out and to say something about it. Well, but what about the rest of us? The AMA in 2020 finally says that race is not biology. Okay, so the American Medical Association. They're getting more progressive, but it took them a long time to get there. And so I was kind of curious about, what do Americans think? And I found a survey and I don't ask me the methodology, I'm not going to talk about that, but only about a third of Americans actually, in this particular survey, stated that they thought race was biologically determined. So we're actually dealing with a society that's, quite advanced in this way of thinking. I don't know about you, but I'm pretty limited when it comes to statistics. So I think it's the one tool in my toolbox that is as close to being objective as possible. And yet, the field of statistics was created by, frankly, a bunch of racists. This article by Clayton is great if you want to read more. I really enjoyed reading this article. If you take nothing else, look this up and read it. I do have a warning that some of the offensive things that come up in this slide is because I'm going to let these white guys speak for themselves, okay? So first you have Galton. He shows up here again. He is the guy who came up with things like regression, correlation, and the normal distribution curve. These are the very common things. You may even heard somebody said something about regression today, okay? And this is what he said. Pearson and his p-value probably is the most commonly used word in research, or quantitative research at least. And here's what he said. Fisher, who came up with significance testing and the Fisher exact test, thought this out loud. Can't see it. Okay. How can you argue? Well, let me just say this. Some people might say, well, that's what they said, but their work stands on its own. And actually, that's how it works right now. You use these tools, and no one really think about what Fisher meant or said, or Pearson meant or said. I don't think you can take an anti-racist approach and think that the researcher is separated from the work. So that's my position. And on a personal note, we use the word, I go back to the p-value example. 0.05 is like the classic statistical significance, 5%. And it's just from a personal note, I come from a population in this country, Asian Americans, that has in the past been less than 5%. And yes, some people took that very seriously and treated us as being insignificant. Okay, so just be careful about the cutoffs that we use about things. Okay, racism in health and science, some research examples. I'm only showing the syphilis study for completeness sake. I hope I don't have to talk about it to you all, that you know about it. I was told that I shouldn't use the word Tuskegee as a shorthand for this problem, this issue, because the problem wasn't caused by Tuskegee. It wasn't caused by the people of Tuskegee. It was caused by the U.S. Public Health Service that did this, okay? J. Marion Sims is the quote-unquote father of American gynecology in the 19th century. And he performed experiments on enslaved African American women, including operating on them without anesthesia. Gregory Pincus in the 1950s tested birth control pills in Puerto Rico with poor women without telling them about the potential side effects, so that even was a research study. More of them had more side effects than they expected, and they did not publish about that. And then here at home in San Francisco, across the street, H.H. Tolan of Tolan Hall, and also Brown and Tolan, and one of the people listed on our website as a creator of this medical school, really spent a lot of the 1870s claiming that the rise in sexually transmitted disease in San Francisco was the fault of Chinese prostitutes in Chinatown and not the white men who went to visit them. The city also quarantined Chinese Americans in Chinatown during the last bubonic plague outbreak in the early 1900s. So basically for about 50 years, any infectious disease problem in San Francisco were blamed on the Chinese. Sounds familiar? There's so much more to be said here, but this can be its own course. Just in case you wanted to look, Nature finally published a total journal set on racism. Feel free to read that. All right, let's take a look at a little about research ethics using an equity and anti-racist lens. Okay, so hopefully this is not news to most of you. This is the Belmont Report and the sort of the traditional approach to ethics that we should respect persons' autonomy and protect those who have diminished autonomy. Beneficence, do not harm and maximize possible benefits. And then justice, the people who receive the benefits of research and the people who bears the burden of research. One reason why the Belmont Report was issued in the mid-70s was that researchers did a lot of experiments on prisoners who had diminished autonomy, obviously, and looked on, and they took on more of the burden of research and got less benefit, obviously. Last year, UCSF issued an apology for the unethical experiments that some dermatologists here did in the 60s with prisoners. I forget what it's San Quentin. It's some of the prisoners in the East. Some of the prisons in East Bay. And just to make the obvious statement that even back in the 70s, 40% of U.S. prisoners were Black Americans. So this wasn't just an injustice toward prisoner. There was also a racist component to it. And again, of course, they claim that everyone was doing it, right? So I want to make sure that whenever we hear that, we go, who was everyone again? And of course, there were researchers at UCSF who weren't working with prisoners. So just to be blunt about that. But the more important thing about this is, instead of us feeling real good about where we are, for us to ask ourselves, what's going on now that we feel really good about, that everyone agrees on, that will be looked upon one day, 5 years from now, 10 years from now, 50 years from now, as completely wrong, biased, racist, oppressive? We need to ask ourselves those questions. This is the Converted. You're here in this Health, Equity, and Anti-Racism Symposium. So you're as far along in this university as most people on this trajectory. But even we, ourselves, need to challenge ourselves. I went back to read the Belmont Report, and this line really got to me. Injustice arises from social, racial, sexual, and cultural biases institutionalized in society. This is the 1970s, by the way. For me and for you, this is important because if all researchers have to know about the Belmont Report, I think when you do your training, they refer you to the Belmont Report. I don't know how many of you click on that link and go actually read it. You're supposed to. You have to know about this. And if you have to know about this, you have to know about injustice to be a researcher. You have to know about racism to be a researcher. You have to know about sexism and so on to be a researcher. No researcher, not just you, but no researcher working with human beings can claim ignorance of these issues. If they didn't click on the Belmont Report, that's not our fault. They didn't click it and they didn't read it. But we expect them to understand these things, not just those who are actually doing the work explicitly. So, again, just to summarize, justice is a fair and equitable allocation of risk and benefits, which requires appropriate representation in research studies. In other words, the population, a participant, or the sample participant should reflect the population that the results are supposed to apply to, right? So have I been controversial? Anybody disagree with what I'm saying? I want to get more controversial since you're all just so out there. Okay, randomness and probability are crucial to the conduct of studies. If your sample does not reflect the population, there is, by definition, a bias in your study. How is it possible that the United States has a population that's less than 60% white, European ancestry or non-Hispanic white, let's say? Our researchers in genomics, which is a huge field, right, are drawing samples that are 80 to 90% European ancestry. Is it a random finding? I used the master's tool, statistics, and did a chi-square analysis. I don't know if they did it right, but I did it. On the likelihood that this distribution is a random sample from our population. And the p-value was less than 0.0001. 1 out of 10,000 chance that this was a random occurrence, that our researchers got these samples from our population. Now, when it's not a random occurrence, it behooves us, I never used that word before, behooves us to explain it, or at least come up with studies to explain it, right? I posit that racism is a possibility. There are other explanations. They could just be completely incompetent researcher. I mean, if you wrote a grant where you said, I want to sample, my sample is going to look like this from a population that looks like that, you're not getting the grant funded. You don't know what you're doing as a researcher, right? So they could just be really bad, but somehow they got funded. You could also say maybe that these are racist researchers. I wouldn't necessarily say that. You could. But certainly you could say maybe there are structural and institutional racism that in our research system that leads to these samples, right? These are all hypotheses, I say. But remember, in research, there's what we call prior probability and posterior probability. And then there are, when you look at it, you have to think about the prior probability. What is the likelihood that anything that you find in this country that's inequitable has something to do with racism? How many people think that's a really high likelihood? High prior probability. So if that's a high prior probability when I'm trying to explain this problem, I can use racism as an explanation, okay? Let me clear what I'm saying here. When the study sample does not reflect the population, it is not just a bad thing. It is not just bad science. It's not just injustice. I think it indicates possible racism. Okay? And you can read 100 paper on diversity of research participants in studies, and the word racism never appears. I know this. I've read them. Never appears. So, yeah, okay, maybe you don't buy it. I only asked you to ask the question, is racism working here? You can answer it yourself, or you can go look up more answers. And if it is, how is it working here? What about research funding? This is a seminal paper in 2011 by Gunther in Science. They did some good stuff in Science. That looked at NIH R01 funding. And what they found at that time, I think that it was over 10, 20 years of R01 funding, Asian Americans were 4 percentage points, and Black American researchers were 13 percentage points less likely to get NIH R01 investigative funding, compared with non-Hispanic whites. And after controlling for multiple variables, Black American researchers remain 10 percentage points less likely to be funded. I think there are reasonable explanations, but I think we should also ask, is racism working here, and how? To its credit, the NIH really did something great with this. They took this, they created a chief diversity officer, they did a bunch of things, and then they just most recently published the most recent funding rates. And everybody's doing better, which is way good news if you're doing research. And second, the gaps among the races are closing. We hope that will be sustainable. Another really controversial thing. People who speak another language other than English, I'm beginning to go away from the term limited English proficiency. I don't think anyone should be defined as being limited in any quality just because they don't fit into something. So it's really bad because I'm using words like people who speak a language. When you write a grant, that takes a lot of space. But people who speak a language other than English has been treated in research ethics mostly as a vulnerable population. That means we have to protect them from researchers who seek to exploit them because they don't understand the study. Right? This is normal. This is actually in our IRB form, it says vulnerable populations, and people who don't speak English is one of them. I find it to be a very odd solution to the problem. If the study information was given in a language that people who don't speak English can understand, then they are no longer a vulnerable population. That seems to me to be a better solution than protecting them, right? Look at the literature here. So emergency medicine research, they did a recent review. 42% did not even mention the language of participants or required to participate in the study. 11% excluded those who didn't speak English, and exclusion didn't get better, it got worse, from 6% to 16%. Pediatrics research, only 9% of studies included those who did not speak English. Now, you can't really complain about the lack of representation of people in your study when you exclude them right off the bat. That just does, you don't get you don't get that as a benefit, explanation for why you're having a problem. So the question then becomes, is it ethical to exclude someone from research because they do not speak English? And if you do, is racism working here, and how? I have to tell you, we're having some pretty serious conversation with our IRB about this very point. And you may feel some of this pain point when it comes. Because if we do implement this approach, this is not national standards, this is going to be maybe UCSF standard, you're going to say, well, yeah, I'm working, if you're working with a particular population, like black people or, white people who speak English, that's your definition of your population, that's fine, right? But you better say that in your study. I'm only studying white people with English speaking, right? You can't just say, my default population, No, say that, and then we'll be okay with it. You're not going to sample anybody else, right? Or I want to study only Asian who speak English. That's fine. I really get really upset when I read papers about Asians in particular. Latinx used to be the problem, but people are getting more sophisticated. They say, Asians, this is the finding among Asians. And their studies were all excluding people who don't speak English. And I'm like, I don't ask for much. I only ask for you to say, these are the findings in Asians who speak English. Don't generalize when you're incapable of generalizing from your sample. Anyway, there may come a point in this institution where we will challenge it, but we also hope to provide the resources you need to do it. Okay, next, someone's going to give me a time check, right? Okay, because I can go on and on. So, I think many of you have heard the term anti-racism or anti-racist, maybe like me through Ibram X. Kendi's work in the book, How to Be an Anti-Racist. I looked briefly for when this term was first used, and I saw it referenced in a speech in 1975. And Kimberly Crenshaw definitely wrote about it in 1989. I put this direct quote from Dr. Kamara Jones, who was our presidential scholar in 2022, because I really like this definition of racism. Racism is a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we call race, that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and saps the strength of the whole society through the waste of human resources. And I think it's great that she followed in that paper by saying that because it is being defined as a system, we can stop focusing on whether a person is racist or not. If you're not feeling this because you feel under attack, hopefully this makes you feel better. Anti-racism is not a fight about individuals. Anti-racism is a fight against systems. You can choose to be part of the fight, or you can choose to be a part of the system. Thank you. Dr. Jones put out the three main tasks for anti-racist work. The first is to name it. Because it's a loaded word. Everybody, gets scared of that word. It's uncomfortable. We often want to avoid it. From clinical medicine, this reminds me of something very similar, death. People don't like to say the word death in clinical medicine. Doctors don't like saying it. Patients don't like saying it. An anthropologist tells us that one of the reasons why people don't really have a cultural aversion to that word is because there used to be superstition, or not superstition, but maybe beliefs that before the scientific era, that if you said something, you call it, right, into existence. Now, as scientists, I think we can all agree that that's kind of not correct, right? I mean, I'm fine with people having superstition. That's their thing. But scientists probably shouldn't be dealing with too much with superstition, okay? And so, if I feel like it's racism, I'm going to say it. Say it, all right? Or at the minimum, do it the way she does it, Dr. Jones, which I love. Is racism happening here? You may think it is, but the best way to do it is not to say, I think this is racist, it's very loaded and people feel attacked. So, is racism? Is racism an explanation? This is why I love being a learner, because a learner can ask questions. Okay. The other thing that's really important about this is you have to ask how it is operating here. Now, what's really important about this is how is what researchers do. How does this work? How does that work? How is this possible? How can we make change? This is a very natural research process to ask how something is working. And then, but the last thing, which is the most important thing, I think, is to organize and strategize to act. Someone asked about Black Lives Matter and advocacy. We had a health disparities research symposium for 14 years. And we changed it to health equity and anti-racism because it's time to go beyond describing things. It's time to act. And it's time to act not as individuals, because we're not fighting against individuals, we're fighting against systems. You can't do that if you don't organize and strategize. Okay? There are typically 4 ways in which people describe racism. I'm sure you may have different, but internalized and interpersonal are fairly clear what they mean. I think you even saw some example of it today. I saw one of the posters where having a black doctor versus not having a black doctor made a difference in terms of racism. But really, we're focused mostly on the institutional, which are the laws, policies, norms, and practices, and then the structural or systems, history, economics, educational, justice, political structure. Now, when we hear people say a lot, and I'm sure you do too, that I don't believe in racism because I've never seen it. Believe it or not, I'll tell you about a project that we did here 2 years ago, where we put out the question about anti-racism into the UCSF community and asked for comment. And some of the comments came back was, I've never seen racism at UCSF. We shouldn't be wasting our resources doing this. Now, I'm not going to challenge someone's feelings and experience. I think it's entirely possible that that person has been so privileged they've never seen it. Or they only believe in things they can see, if that makes sense. And that's the iceberg here. There are many types of racism that's very overt, right? Someone getting into somebody's face, for example. But there's all these structural stuff going on underneath that water, the big part of the iceberg that you don't see. So, let me see here. So, because this is a new concept in health research, I think the first paper talking about anti-racism in health literature was only about 10 years ago. And I think it just became a mesh term. You know what mesh is, in PubMed searches. So I decided, hey, I can come up with some principles just as well as anybody. I'm a doctor. I'm an MD. I don't do PhD work. I don't know anything about theory. I don't know anything about principles. But I said, I can try. So I came up with this AEIOU principles. And if you can just remember the AEIOU, even if you don't remember what they stand for, it's cool. Okay, A is for accountability. Change will not happen without data and widespread dissemination of the data, good or bad, and that the people in charge must be accountable for the findings to the people they serve or work for. This includes data, evaluation, assessment, and transparency. I was on the CTA's National DEIA Committee, and we asked the question, how many of you CTSAs, these big scientific grants, have a dashboard on the diversity of your workforce? And a lot of them didn't have it. A lot of them said, we can't have it because we're in a state where they won't let us do it. So even something as simple as how diverse is your workforce is not transparent. We are transparent, right? We have that. You can find it. So I also think that accountability is also having to do with resources. So you know the problem and you have to dedicate resources to address the problem. That's part of accountability. E is for engagement. This whole morning's sessions have all been about engagement, engaging the community. This speaks to the part of organizing that Dr. Jones was talking about. This work must involve the people affected by it, starting from the assessment to planning to implementation to dissemination and then to sustainability. Okay, I have a whole talk on community and stakeholder engagement, but this is all I'll say about it. But if you can say for sure that if a project isn't engaging the community, it's probably not an anti-racist project. Okay? I is for individual-centered institutional change or systematic change. So this is my own thing, and I struggle to explain it. But the way I explain it is this. The outcome, the accountability outcome is institutional, right? The institution needs to show that it's more diverse, okay? That's the accountability piece. And so the institution has to do better. But what it can't do is treat individuals who are affected by the oppression as a tool to achieve that outcome. Does that make sense? It has to be individually centered institutional change. I'll use an example, and I apologize to those of you who do this type of work because people get very upset at me when I use it. It's a pipeline program, okay? The word pipeline, I'm an English as a second language learner. The English language fascinates me. So when I hear pipeline program, I'm like, ooh, big tube, take some people, mush them in, push them through. Sometimes they leak out, they force out the pressure, and a few of them come out on the other end, right? That's what pipeline sounds like to me, and actually in implementation, that's kind of like how it is. You take 500 students, you select them, 100 of them go into your program, 50 don't end up going there, 50 apply, 25 accepts, 10 succeed. That's a pipeline program. And that's why we are because that is the paradigm, that is why we're still in a world where diversity is lacking. Okay? I also think the word pipeline for a lot of other people mean Keystone Pipeline, which, please, you don't want that association with your work. If you're tech-centric, how many of you are tech-centric? Come on. You all have a smartphone. We use the word network. The network idea means you can be an individual, and you can go here, or here, or here, or here, and then you can create the wide web of diversity. So if we train you to do one thing, and you didn't end up doing it for whatever reason, but you choose to do this other thing, where you became a leader, or whatever, we think that's a win. We don't think that's a loss. We don't think you're a failure, right? If you're nature-centric, there's a group of people who do this work on sort of graphically depicting things. The concept of a river, really, so we should have river pipe training program, and we should have network training program, and we should no longer have any more pipeline training program. Sorry. Okay, quickly, opportunities, the bottom line is, you go back to Dr. Jones' statement, a waste of human resources, okay? So when you do anti-racist work, what you're doing is not to limit opportunities. This is a classic oppressor tool. If you get something, I don't get anything, so I'm going to fight against you, right? That's the decreasing the opportunity. What we're talking about is increasing opportunity. If everybody gets what they need and want, we will have more opportunities for everyone. That's a principle. And then the last one is unity. That, again, we hear about intersectionality. We hear about, what about transgender rights? What about black rights? What about Asian rights? The whole point here is it's fine to promote all of those things, but it's also important for us to think about solutions that lift everyone up. For two reasons. One is it's easier. You can form better coalition when everyone sees themselves benefiting, right, instead of fighting against each other. But the other is there's intersectionality. So if I ask you what's your identity, you probably have 3 or 4 or 5 or 10 different identities. And so how do you do that when you're like, I'm an Asian man? Well, I'm an immigrant. So what about men, immigrants? It's the whole thing, right? I also, some of you are unfortunate to have heard this talk several times before. So I'm going to give you a new thing, a new you. I was going to say the new you is you, but that sounds cheesy. The new you is uncomfortable. Because since I've been doing this work, I'm really uncomfortable. There's many uncomfortable situations that you get into. And actually, that's exactly when I know I have to pay attention. That's when I'm being challenged. That's when the heart's work needs to be done. And I'm like, okay, I have to learn to embrace the uncomfortable, which is really bad for my self-care, but still, right? Don't run away from the uncomfortable. Maybe not deal with it that moment, but then go back and say, why was that uncomfortable? What can we do to resolve the discomfort? Okay, questioning the nuances of neutrality. So we know that neutrality is integral to the research process, right? Most scientists are like, if you told them they were neutral, they'd be like, oh no, that's terrible, because they want to trust their findings. And that's true. However, I also posit that neutrality is integral to the perpetuation of injustice and unjust systems. This is the basic fundamental anti-racist stance. Okay? Anti-racism challenges neutrality when it is inappropriate. And pretty much in every structural system, it is always inappropriate to be neutral. It may be okay to be neutral when you're studying a cell, right? But not when you're studying a system. I did put the scale of justice with the 1% versus 99%. I did want to say before I go leave that slide that we also have a system that so people who do system studies says the system is optimally designed to produce the observed outcome. So whatever you're seeing is what that system was designed to do. Otherwise, it won't happen, right? We have a system where we have extreme wealth inequality. Our system is designed, by definition, to produce extreme wealth inequality. And we know in this country that wealth inequality tracks with race inequality. So our system, whether it's economic, political, whatever, promotes inequality. So if you want to sit in the middle in that system, you are signing off on inequality. Sorry. Race, meritocracy, I don't want to spend too much time on this, because in this audience, you know that when you see a staggered start, it doesn't mean someone has a head start. It depends on the structure that they're in. This is the whole argument behind affirmative action, right? So if you run this race and everybody stays in their lane, right, and you have the same finish line, there is no advantage here, right? The person looks like they're starting ahead is going to cover the same distance as the person who starts behind, right? So that's what the idea behind affirmative action. But I'll flip that around and say, when we talk about meritocracy, we act as if that doesn't exist. There are people who starts ahead. If you're the son of, Elon Musk, whatever the kid's name is, he's starting with a head start, right? And if he's going to compete with somebody by crossing over his lane to run against somebody else, he's got an advantage, right? So when you're measuring who finishes at the end and what the quality of merits are, you have to take that into account, right? Anti-racism challenges the measures of meritocracy, both the independent predictor, which are the things that we talk about like grades, GPA, and the outcomes, who get the job, who gets the promotion. And then for how colored, anti-racism challenges the primacy of quantitative data over qualitative data. Remember, just because you can count it doesn't mean it counts, right? And just because you can't count it doesn't mean it doesn't count. Make sense? I'm a philosophy, but that confused me too. The whole logic behind that really confusing. But really, just because you can't measure it doesn't mean you can't include it in your evaluation of someone's value or merit or whatever it is that you're using it for. That's what holistic review is about, right? Individualism and innovation. So when we also think about meritocracy, we count individual successes. You can't believe the number of times when I look at papers and people are like, oh, yeah, you're fourth on that paper. It wasn't a big deal. You're not first author. First author, even though you have a team of 50 people, the first name on that list counts, right? I say you can't spell genius without an I or a U or an us. You can't do this work if you're by yourself. There is data that diversity leads to more innovation. I'll show you in a second. And I think that you can say that anti-racism in science manifests itself in team science and in the diversity of the research team. And then we expand the definition of team science, because usually when we say team science, we mean like anthropology and biology or something like that. We expand that definition to include communities, because I don't know, you can get a PhD in community, can't you? There are lots of people with PhDs in community. That's why you're asking them to serve in their advisory board, right? Things like that. I found this paper to be incredibly important. I hope that you all look this one up, because you can explain it to me. I don't understand the methods. This is called the diversity innovation paradox, which was published a couple of years ago in the Proceeding of National Academy of Sciences. They look at almost 1.2 million US doctoral recipients in the last 50 years. They follow their careers looking at publishing and faculty positions, and then they use the methods of text analysis and machine learning. That's the part I don't understand. Like, I have no idea what they're doing here. And I just simply quote their results, just so you, just to say. Underrepresented groups produce, and underrepresented in this case is race and gender, some women. Underrepresented groups produce higher rates of scientific novelty. This is a big study, 1.2 million people. I'm going to use this data against anybody who says, prove to me that diversity that leads to more innovation. Novel contributions by minorities are taken up by other scholars at a lower rate than novel contributions by the majorities. So this is not about merit. Equally impactful contributions of minorities are less likely to result in a successful scientific career than for majority groups. Now, I don't know about you, but this is not about merit. This is not about science quality. This is about what we do with people just because of who they are and where they came from. The implication is that academia discounts diversity's role in innovation and partly explains the underrepresentation of some groups. So all I ask you to say is, it's racism operating here and how. Trust, this comes up a lot in research. And I have to say, for the first 10 years of the health disparity research, which is basically 1993 to 2003, paper after paper after paper talk about trust, and that's where the public health study in Tuskegee comes up and all this stuff. And after a while, you get sick of it. Lack of trust, but it has been shown. So I'll just quote from one of my colleagues, Sam Saha, in JGIM on a study of the VA hospital system, quality of care in the VA hospital system. Minority patients harbor less trust and more skepticism about medical interventions. Now, that's a statement that's true on its fact, I think. The question is, why do we keep saying that? Lack of trust, however, is not a key factor in research participation. So you get this a lot, too. Like, people will say, I didn't recruit a good sample because, black people don't trust researchers. As if somehow that explains why you couldn't do it, right? But actually, forget about that. The science doesn't show that to be true. There is lack of trust, and there is lack of participation, but the link between lack of trust and lack of participation is not established, if that makes sense. I'm not saying it isn't, but that just can't be an excuse that we use to justify lack of participation. There was a paper I'm putting up here. I'm hoping that someone will read it too. It's obscure. Look at this journal, AJOB Empirical Bioethics. But I loved it. It was like 335 surveys of Latinx and other individuals and black people. And look at the question of what they mean by, say, trust or lack of trust. There's general trustworthiness. Then they break it down, that construct, into 4 categories: trustworthiness, discrimination, deception, and exploitation. So it's not just about trust. And the reason why I put this one up here is, let's stop talking about lack of trust and let's start talking about lack of trustworthiness. Are we trustworthy? Okay, I have about 1 minute. Can I take two? So I want to talk about quickly some things we're doing. Big 2020 led to a lot of changes. We created this task force, and we did it very stakeholder engaged. We came up with 4 categories that this institution will do in research: accountability, as I mentioned, anti-racism scholarship, diversifying the workforce, and promoting community-engaged research. In the interest of time, I'm going to go through this really quick, but I wanted to say, number one, my office exists because of this work. From the time that we conceived of the task force to the time this office was created and I was appointed, 2 years. That's actually a pretty rapid pace for institutional change, and that's the pace we accept. We don't accept disparities, 20 years later, disparities still there. We don't accept that. Okay? We have a task force that is now an oversight committee, dashboard of research participants. So we have a dashboard of research workforce, but we don't have a dashboard of research participants. You don't know how hard it is to do, but we're going to have one soon, in the next 3 months. I promise you, at least for NIH study. That's the one we can do. Okay? Anti-racism scholarship, for those of you who are looking for new careers, this is it. This is the new field where the innovation is going to happen. We want to do this at UCSF. We want to teach you all about it. The best news about this is that, she's still here. Dr. James, are you still here? There she is. Dr. Navarro has committed to helping us create an anti-racism consult service for our researchers that we hope to launch in 2024 early. Right, Dr. James? So if they say to you, I don't know how to do this work, we're like, come to us and we'll talk with you about it. This was something I'm really proud of, although I had nothing to do with it. The task force started in 2020, and as quickly as 2021, UCSF created an internal pilot mechanism to fund anti-racist projects. Okay, I think that's great. That's how we do things. We're not going to sit here and talk about it all day long. We're going to put money out there really quick. These are the first 3 projects. I just saw the poster from the ARIES project, which is the mental health emergency one. Last year we had 7. This last spring we had 3. And the main thing is that it covers the gamut of all the populations that we think about. The last one is actually, was just due like last week. So, but it's twice a year, so please. The main thing about doing that project is that you have to have community engagement. If you don't have community, I told you, if you don't do community engagement research that ain't anti-racist, you can't submit we had a great submission in every way except community engagement. And we were like, oh, how can we turn this down? We turned it down. Diversifying the research team, I'm not going to go through that too much. I did want to mention SF Bill, which is a UCSF San Francisco State collaboration. To me, I think it's silly to say we don't have enough diverse trainees. I think it's silly. It's just crazy silly. Like you go to San Francisco State, there are thousands of STEM students who are underrepresented. Okay? If you keep going to Berkeley and Harvard, okay, fine, there are not enough trainees. But Cal State system, thousands of them. We should be working with them to get them into our school and our research program and our staff, okay? Because they don't have to worry about the cost of living because, of course, they already know how expensive it is here, right? This is the program that we do. We just got some additional funding for it. Would love to talk to you about this. We want to expand this model to all the UC and the Cal States. And there are many efforts in this area, okay? I did want to do a little bit of celebration, or maybe not. This is one of those slide, cup half empty, cup half full slide. So since Renee's office was established in 2010, 2011, the underrepresented minority proportion in our faculty went from 6%, which is awful, to 12%. So it could be better. It's definitely better. It's doubled. So the glass half full it's double. The glass half empty, of course, is only 12%. I included all the other ones. We're doing very well with women. There are issues around tracks and all that stuff. I'm not going to get into that too much right now. For students, I was really excited about this. So just to, this is very complicated. So the first 3 are all students, right? So all students at UCSF. URM went from 13% to 24%. All racial and ethnic minority, and that's my commitment to including Asian, because when we do URM and non-URM, the Asians get lost. REM, I call it my new term, REM, my favorite band, 40% to 56%, right? And the women have been good and flat. For the medical school, 20% to 36%, so that's pretty substantial. And actually, the good news is the last 2 admitted classes to the medical school is 52 and 54% URM. Now, we're doing this in the face, people talk about, well, we're going to do another affirmative action. We have not had affirmative action in California since 1996. So number one, kudos to everyone who made this happen, but also, you can't use that as an excuse. We're going to go around the country and say, yeah, fine, okay, no affirmative action, let's fight against that and go out and vote and whatever. There's things to do there, but even in the absence of affirmative action, you can still get these outcomes. For PhD, we're an important group. We went from 11% to 21%, so almost double. Still small numbers, obviously. And then I'm done. One last thing. I'm just going to finish. How can we do this? Many of you already know how to do this. Always ask about who is accountable and how transparent are the work and the outcome. Always ask about stakeholders and community engagement. Always ask how your work interact with our current system in ways that can lead to more racist outcomes, either anticipated or unanticipated. And how can you ameliorate that either in the research itself or once you establish your career as a scientist or a leader. I say always because we hope that there's always someone in the room who will believe this and say it. Don't make only the minority in the room say it. You know you're in a good workplace, and I am in a good workplace when the white people are going, what about this? What about that? Diversity, racism, anti-racism. That's where you want to be. You don't want to be in a place where it's tongue talking about language again. Diversify the team, we know this. Moderators, we're going to skip through this. This is pretty barriers and power, though. This is important. I saw someone did a project on predisposing, enabling, and all that stuff. One thing about being a minority person that you know very well is that just to survive is strength, right? Just overcome the things that you come, just for them to show up. There's power there. So don't always talk about barriers and don't always talk about solutions. They have knowledge of the solutions. They have the power to survive. And the most importantly, and this is to your point about research, is it the right endeavor? Who has the question and who has the answer? Thank you.
Thank you so much, Tung. Let's give him a big round of applause. So we do need a microphone up here for Tung. Can we? So we're going to spend about the next 10 minutes for your questions, your comments, your thoughts, everything. We invite everyone to share. I felt a little uncomfortable, so I think you achieved your goal, Tung. Yeah. Okay. I think Roberto has a question back there. Oh. Roberto, and then...
Yeah. Roberto, we cut off your mic. It's a systematic oppression thing.
Thanks. Thank you, Tung. I love this talk. I've seen several iterations, and it's fire every time. Thank you so much. My name is Roberto Vargas with the CTSI RAGE program and Community Engagement Program and Center for Community Engagement. We missed you yesterday at the AOCI retreat, Tung. So this effort to put together curricula around anti-oppression at UCSF, and you've talked so much about what we need to help inform folks in the research enterprise and in medicine around liberatory frameworks. And I'm just curious if you could share something quickly about your thoughts about where we need to go if we're going to be bold around supporting efforts like that.
Yeah, no, that's a great question. First of all, I think, and correct me if I'm wrong, Renee, but all the schools have to have an anti-oppression curriculum initiative now, right? Yeah, so that's great. That is expected, that you have to have it. So you teach people about it. But I think, one of the acronym I didn't use today was SASE, which is synergize, amplify, silo, bus, sustain, and initiate. We don't have to initiate everything. There are many. You just saw today how wonderful people here are and what kind of work they do. Let's find good examples, synergize with them, amplify them, sustain them. We don't have to initiate everything. This is back to the individual researcher is being the innovator. Like, you don't get any credit for amplifying somebody's work in the traditional research world. You have to create your own stuff, right? That's the innovation part, and that's not really the way to do this work.
Thank you. Jen?
Hi, I'm Jen James, she, her. Great talk. You're going to have to stop saying you're not an expert in this any moment now, Tung, because you really are. I'm going to ask what for me feels like an uncomfortable question as someone who's very much in this work. And I think, you gave some great examples of thinking about how racism's operating here. And I was thinking about the example of research on people who are incarcerated and wanted to just add to that like one of those researchers is still on faculty here, has published more articles since this news broke than I have in my entire career, which is impressive, makes more money than me, right? This is present, this isn't actually history, right? I'm sure if we all listen carefully, we can hear the ding of someone having a race-based medicine article accepted in a high-impact journal. It's happening today on campus. And so, when I think about these questions of, are we in the fight or are we in the system? Are we resisting? What does that look like? I'm always so struck with feeling like the best thing I could do, the pinnacle of my career is like, I go out, I get a huge $5 million NIH grant to do anti-racism work. It's community-based, it's awesome, it's radical. That means there's also a $3 million check coming straight to UCSF to do things with that I don't know what they're doing with it. Nobody tells me, nobody will tell me. That supports what is still a present racially racist-based medicine, racist research enterprise, racist history. Tolan Hall's not here right now, I guess, because the building looks pretty destructive, but it's probably coming back, right? So anyway, how do we contend with that? How do we think about, I think a lot of us would say, don't put more money in policing, don't put more money in prisons, but we're actively putting more money in UCSF, and I want us to because I like my job. But is that a contradiction? How do we think about reforming versus transforming versus abolition when we're in this work?
First of all, thank you, Jen. I hope you weren't uncomfortable because I feel like that's what a lot of us feel. And I even think now that it's very funny to go from not being in a leadership position to being in a leadership position. That's very uncomfortable too, right? But I can say this, two things. One is it's a work in progress, okay? And the one reason why I wanted to end with some of those data slides was to show you how far we come in 10 years in terms of diversity. And that even though we have been, and I have been a loud critic of this institution in terms of its diversity, we are making progress. And that's important to acknowledge. We haven't made the progress we need to do in terms of equity or inclusion or belonging or anti-racism. But I think we need to keep on working in it. I certainly can say that I will be a part of that process. I'm going to constantly challenge. One of the things that we try to do, which hasn't happened yet, and Renee may not like me saying this out loud, but we've been saying, for example, if you give money to UCSF as a philanthropist, that we're going to take a tax, and the tax is for community engagement. And that's the kind of directly addresses your idea of when I bring money into UCSF, what am I bringing money in for? And the idea behind that, I just to say, is as somebody who does community engagement research all the time, is, if you do a bench science, you get recruited to UCSF, they build you a lab, and buy you machines that's hundreds of thousands of dollars, right? If you do work in the community, what's your lab? Your lab's in the community and the relationships that you have. But no one buys you lunch for your community, okay? So there's a huge disparity here that we need to figure out, and I want to be with you pushing leadership on saying things like, well, hey, why are we giving money in this direction and not in that direction? So that's all I can say.
Hi. Can you hear me? Yeah. Hi, Carrington, he, she. I'm sorry, he, him. And my question is regarding the recent study that came out from UCSF about the homeless. And alarming number for me was that 82% of the people estimate of the 171,000 unhoused people in California are people of color. And we always talk about the mental health, we talk about the drug addiction, but when do we begin to talk about anti-racism and that difference between the haves and the have-nots in California that has resulted in 82% of the people out there being people of color? And isn't anti-racism an integral part that we need to start including in our advocacy around the unhoused?
Absolutely. I think homelessness is one of those examples where it isn't just about housing, to be perfectly honest. It's like the nexus of all the bad things, all the inequalities in this country come to become very apparent. So when people talk about, the problem of the homeless people, they are talking about the problem of America. And that includes racism, that includes income inequality, that includes who's in power and determining what gets done, that includes the lack of mental health care, many, many things. But I totally agree with you. I am proud of the fact that that study did come out of UCSF, that we have a BHHI, the Homeless and Housing Initiative, that our people working there are approaching this the right way, which is well, Margot Cushao does say homelessness is a housing problem, and it is a housing problem, but it goes beyond housing. And I totally agree that racism is a huge part of it. So.
Okay, we have time for one final question.
Hi, Tung. Thank you for a great version of this talk. I'm Rana Barar. I'm the Senior Program Manager for Community Engagement and for the RAGE program at CTSI. Come to us for consultations, just a plug for CTSI. Along the lines of Jen's question, it's award season, Nobel Prizes, MacArthur Genius Grants. In a world where the research questions are generated by the community and the research is done in the community, by the community, with the community, what do those kinds of individual accolades mean? What do they look like in 25 years when they aren't quite so individualistic?
Yeah, great question. I did skip a slide, community engagement, one of the four pillars. And one of the things that we are working, and you know very well, Rana, is that we're trying to make sure that community engagement is a promotion criteria. Not as service, because that's, it actually included in UCSF faculty promotion as service. We don't think it's only service. We think it's research, we think it's impact, and we want community engagement to be a part of it. But there's a whole sort of other issues that we have to resolve, right? So, for example, community engaged work takes a lot longer. You just can't rush it. And if you're on a 6-year assistant professor timeline to get promoted, and it takes you 3 years to build your community coalition, and then a year when things fall apart because something happens like COVID, what are you going to do, right? So I think there are a lot of issues we have to resolve there. The Nobel Prize was named after a guy who invented explosives, so I don't care.
On that note, we are going to break for lunch. Lunch is to the side here. I invite everyone to return about 1 p.m. to the poster session 2. And we also have great plenary presentations this afternoon, so I hope you'll join us again. Thank you.